Okay. السلام عليكم ورحمة الله. معكم Mohamed Hegazi. I'm an assistant professor of bone marrow transplant here at University of Louisville. And النهارده هتكلم على one topic من التوبكس اللي إن شاء الله هتكون in a series of oncology related topics throughout the year between me and my colleagues. النهارده أنا هتكلم على a quick covering oncologic emergencies. التارجت audience في البرزنتيشن ديت هيكون medical students and residents more, but of course experienced oncologists and people who would like to share their thoughts are always welcome. أنا يعني التوبيك هيكون عبارة عن حالات واتكلم عنها بسرعة بشكل موضوعي على ال diseases that's underlying. So this is a 68-year-old gentleman who presented with dyspnea, dry cough, chest pain, and facial swelling over the course of several weeks, and his past medical history included hypertension, dyslipidemia, as well as a heavy smoking history. Vital signs كانت تمام, and then take a look at the guy's face, and here he is. And as you see on his chest, you're seeing some of the superficial veins are engorged, and they're more or less building anastomoses that are not supposed to be in that area typically. And below there, you're seeing him more swollen. This is a picture of somebody who's way more swollen, as well as with what looks like deeper level of swelling. دلوقتي لما بيجي عيان زي دوت للطوارئ with these complaints, the differential is quite broad, and malignancies by itself has a long list of potential causes. This can be from lung cancer, small cell or non-small cell, can be lymphomas, thymomas, and also some other not as common malignancies such as germ cell tumors, mesotheliomas, and not very commonly mediastinal lymphadenopathy can do that. Now, non-malignant causes can also happen, such as supravenous cava thrombosis, goiter, fibrosis, mediastinitis, prior chest radiation, an enlarged right paratracheal lymph node, and an aortic aneurysm. Possible causes. خليك معايا ثانية واحدة بس عشان عايز أشوف كده لو Okay. All right. So in this case, you get a CT scan, and you see this invasive mass right here, involving, as you see, the vena cava completely blocked. Contrast isn't going down, and you're seeing the encroachment from the side of the left lung in the area, and you can see that also on the X-ray. Now, what would you do next? So this is a question that you always want to do is, this is an emergency, yes or no? Okay, what should I do now to save this patient's life? And they went with a bronchoscopy, and a biopsy showed a small cell lung cancer. So in the case of a small cell lung cancer, what would you do in a patient who has a superior vena cava syndrome? Most of these emergencies are they are oncologic emergencies, but most of the interventions and the treatment aren't done by an oncologist, and so except in certain situations that I'll explain right now. So first, you need to decide how bad is the situation. Is this a life-threatening SVC syndrome on this grading system, where it's causing not just a swelling in their neck or the face, but also an increase in the intracranial pressure, causing cerebral edema in the form of confusion or obtundation, or causing stridor and laryngeal edema or some hemodynamic compromise. لأن لو أنت وصلت للحالة ديت, your interventions cannot be something that needs hours or days to work. You want something that works in minutes. While if it's just edema in the head and neck with some congestion, cyanosis, and plethora, that's a mild form of SVC syndrome. So this is a proposed algorithm that when I'm teaching the students here, I go to quite a bit, and the residents. Always number one is, of course, you do a good physical exam and get history and the CT of the chest to get to the point of what exactly is the situation. But then, if you believe this is a malignant SVC syndrome, your grade will dictate your intervention. So if you're grade 4, which, as we mentioned earlier, you have an increase in the intracranial pressure with cerebral edema or any kind of hemodynamic compromise, then you will have to do emergent stent to be placed in contact. That would be done by either vascular surgery or interventional radiology. And if it is a thrombus, you can use thrombolytic therapy to get rid of it. But if it's a not so bad of a grade from the form of some edema in the head to as bad as some headache and dizziness with a mild or moderate laryngeal edema, and you're still able to push through, then maybe you have some time, or you can get your biopsy and develop a stage and a tumor specific definitive treatment. The definitive treatment is always dependent on the cancer. So if you have a surgically managed tumor like germ cell tumor, those or thymoma, those are typically you either give them chemotherapy, try to melt it away with it, and then take them to surgery and resect whatever is left there, or take them to surgery right away if you feel things needs to be done. However, on the other side, you might have cancers that surgery is not usually the typical approach, such as small cell lung cancer. Chemoradiotherapy would be the way to go, and that's how you can treat a patient with small cell lung cancer, for example. Chemoradiotherapy is the way to go. A lymphoma, chemotherapy will melt it away. And germ cell tumors in general, you can get them taken care of with chemotherapy right off the bat. If you have a tumor that is not as sensitive to that you don't typically go for surgery right away, and they are not the most curable with just they're not going to be cured with surgery alone, then you would see where's the stage, what stage is this patient, and then you proceed with that. Would that be a radiation therapy and followed by chemotherapy as a long-term plan to get the disease under control, or immunotherapy now as non-small cell lung cancer, as well as small cell lung cancer has it, but now we're dealing with an emergency, so you have to do things that works faster. So immunotherapy is not as fast as chemotherapy in these situations. And now, if you're talking about a pleural mesothelioma, or if the patient has a very poor performance status, then you're, not going to take the patient to surgery. You don't think chemotherapy and radiation is going to be a good option in this patient because of the patient's overall condition is poor, then doing a stent would be the way to go. Okay. Sometimes you would think of steroids in cancers that are sensitive to it. Head elevation and diuretics as the way you would approach increased intracranial pressure in a critical care situation. Typically, steroids are good for lymphomas. Thymomas do listen to them, but typically you have to go for a surgery for thymoma with some taxanes and a platinum therapy prior. Chemotherapy for small cell lung cancer, and we've talked about all the other stuff. All right, we mentioned these as the differential diagnosis for SVC syndrome. Most people, though, present with what's written on top. So this is from the most common presentation to the least common presentation. And you definitely see that they seek medical attention earlier than when it's becoming really serious. So it's more or less edema and neck swelling and chest veins becoming more engorged is what's more common, and then respiratory symptoms. Okay. You will then notice that it gets serious, but usually if you wait until then, the patient's condition is already behind. But it's still dependent on the pathology. So you can cure a patient still from their disease if it's a curable disease, even if they present in this condition. But early on, it's an emergency that you have to intervene with. So just a little bit of why is this happening? It's typically because of shunting. This shunting can happen in multiple forms of cava-cable shunting. Would that be superficial, as what you see here on the right side, or deep, as how you see in the diagram on the left, and also in the CT scan you can see with contrast there that the anastomosis are built up quite a bit, and this takes time to develop. All right, so from this is, as I use this usually as an interactive approach with medical students and residents here. And would you call this an emergency? Yes or no? Would you call that true or false? Is that an emergency? The pathophysiology of the upper human body increases venous pressure. Yes. Okay. Is it life-threatening clinical consequences of this are common? Is that a common thing to have it? Nope. Most of the time not. An underleaf SVC syndrome is life-threatening. That not always the case. You don't have to call it a life-threatening, especially if it's in an early phase. Cerebral edema is a feared complication. That's true. That's usually late. And then cerebral edema in SVC is common. That's not true. Patients with SVC syndrome caused by lung cancer generally have a good prognosis if the SVC obstruction is relieved. That is not true. Radiation therapy prior to tissue biopsy to relieve the SVC obstruction is advised. You will not hear an oncologist ever saying to radiate a tissue before you get a biopsy. So that should always be wrong. If you really can't wait to get a biopsy, then stent the SVC and then get a biopsy. All right. So this was SVC syndrome and how it is presented and what are the interventions that you have to immediately do or deal with. I'll move quickly to a completely different topic as we will jump around between different hematologic emergencies. So this is a 36-year-old man who comes in with fatigue, rash over his chest and arm, and bleeding from his gums and nose. And then the labs show white count 78,000, 65% blasts, hemoglobin is 7, platelets is 20. He has potassium 5.8, bicarb is 20, calcium is 6.8, and creatinine is 0.9. So what are we looking at here, or what are we fearing? Uric acid is 11.2, and phos is 4. So this is elevated, this is down, this is up, this is down, in the setting of this with that. What are we thinking of here? So whenever you see this, always the first step to do when you have a patient like that is give them fluids. You'll never be faulted to give a patient who has what looks vaginally as tumor lysis syndrome from a possibly underlying acute leukemia, fluids. So start with fluids, and when we say fluids, you hydrate them as much as you can hydrate. And this is a young guy, so you're not worried about their heart and lung, so we'll load them with fluids. So we go with 250 or 300 mLs an hour after you bolus them with a few liters, and you're at a race with time, because right now the creatinine looks normal, and when the damage settles and the crystals of uric acid are deposited in the kidneys, then you are dealing with a much more difficult situation to counter back. So IV fluids is always the way to go, and dialysis. Urine alkalization is actually not 100% agreed upon. Some people are big fans of, and some are not. Allopurinol, remember, allopurinol is not going to lower your uric acid right now. It's going to stop the production, but it won't lower what already has been produced. So if you get to that point, you'll have to use raspuricase, which will then break down your uric acid and bring you to a better situation. So with that, you look at uric acid. So that's how you define tumor lysis syndrome. The uric acid over 8, potassium is 6, and phos is higher than the upper limit of normal. With the calcium that is low, that's what gets you. So it's more or less as the correlation between these numbers that gets you to realize that what's going on here. These are the feared complications that you don't want to end up with, either renal failure or more serious cardiac or neurologic complications. So that's something that we always have to keep in mind and make sure that we don't get there. So what are the causes? So we talk a lot in hematologic malignancies in general about tumor lysis syndrome and the risk of tumor lysis syndrome. But what are the diseases that you are worried about? Are you worried about tumor lysis syndrome in acute lymphoblastic leukemia, or are you worried about them in solid cancers? And you can see here the percentages of patients who develop tumor lysis syndrome and the different tumors that are originating from. Always, acute lymphoblastic leukemia would be number one, and non-Hodgkin's lymphoma, especially the more aggressive non-Hodgkin's lymphomas, such as Burkitt's, those would be the worst. And when you get those patients with, if you add these two alone together, you're talking about north of almost 70% of the cases of tumor lysis syndrome are only from these two categories. Acute myeloid leukemia, we're always looking for it. In chronic, in CLL, it almost never happens in pediatrics. It's a very rare disease in pediatrics to begin with. But in adults, we talk a lot about tumor lysis syndrome in patients with CLL when their white count is 500,000 or 600,000. But the incidence is not that high compared to ALL. And same applies for Hodgkin's lymphoma, which is very rare percentage-wise. So these are things that we look at. You don't see any myelomas here, but you might see a very small number of cases of myeloma who would develop tumor lysis syndrome. So that's important to keep in mind. All right, so risk factors for tumor lysis: Burkitt's, lymphoblastic lymphoma, ALL, DLBCL, or solid tumors with a high proliferative rates. These are usually your small cell lung cancer and others that are at a very high rate of proliferation. The bulk of the disease plays a big role. If a patient had an underlying kidney problem, that's a big problem itself. And a baseline, if the uric acid is already 7.5 or above, this patient is already starting with a deficit because they're on the border of their uric acid already pushing up against the numbers. All right. We typically break it down in patients. Certain diseases are high risk regardless of what's going on. And certain diseases, they become high risk in certain settings and lower risk in others. So, for example, Burkitt's lymphoma, lymphoblastic lymphoma, are always high risk, while DLBCL would be an intermediate risk, which means you have to do something still. While indolent lymphomas, non-Hodgkin lymphomas, you're not worried about those generally. Acute lymphoblastic leukemia, it's a very high risk when it's over 100,000 total white count, become intermediate risk, which when it's between 50,000 to 100, but when the counts are less than 50,000, you can call it low risk. AML become a high risk disease as the white count more than 50,000, especially when the population is monoblastic. CLL is never high risk condition, but when you and now CLL has more than just those who are being treated with fludarabine being an intermediate risk, but also those who are being treated with venetoclax, which is the BCL2 inhibitor that we use more common now. It's approved in first line as well as in relapsed and refractory disease, and it can predispose to tumor lysis, can cause tumor lysis, and we stage the doses of the drug into their system and also keep them on allopurinol through. So that's important. So in low risk cases, you don't have to put the patient on an intervention for it at all, but monitor them and clinically judge what you think is appropriate. However, in intermediate risk and high risk, that's when you have to always do something. So IV fluids and allopurinol is always the way to go in intermediate and high risk, but add into that respiricase in certain conditions where you believe that the patient's risk of developing TLS is extremely high. Respiricase therapies is the one of the fastest ways to control the disease, the hyperuricemia and the consequences of that, and you do not want to deal with those consequences, especially cardiac or neurologic toxicity. So these are things that we need to keep an eye on. And this is just a reminder of how and where each of them work, the two agents that we mentioned, allopurinol. So the allopurinol is blocking your xanthine oxidase, so it's not getting rid of the initial uric acid that is already made. It's going to lower the production of more uric acid, while the respiricase will, convert uric acid itself by the urate oxidase into allantoin, and that way you lower the uric acid. All right. We typically so these are recommended doses, but if the patient has good kidneys, we're typically giving them 300 milligrams twice a day. If we're worried about tumor lysis syndrome, even before we start the treatment, and if a patient has renal failure, we give them that half of the dose. Respiricase is a very effective therapy. The only, I don't think I had to give yet respiricase more than once in cases of tumor lysis syndrome, because when you bring it down, typically all your other interventions have kicked in to lower the production of uric acid down the road, so you're not in a condition where you have to give a second dose of respiricase. Of course, you can say contraindicated in G6PD deficiency, but if you're in an emergency, the testing for G6PD might not be readily available for you, but you can get the results down the road. All right, so this is just a comparison of how fast does allopurinol effect go compared to respiricase. So within 4 hours, the respiricase have done the job, versus allopurinol it is not getting rid of, as I said, what's already made. It's working on stopping any further production. All right, so now we talked about severe vena cava syndrome and tumor lysis syndrome. We'll switch to another disease. So 68-year-old with pathogenic history of diabetes and hypothyroidism presents to you with constipation, polyuria, lethargy, and poor memory recall. First you think, okay, what's going on? Is this patient developing some sort of dementia, or what's going on here? But you get labs, and the white count is 9,000, hemoglobin is 9.5, platelets is low, but not that bad, 115, creatinine is slightly up at 1.3, his protein is 9.9, and his albumin is 2.5. You see here there's quite a bit of discrepancy, or a gradient, between the total protein and the albumin level. So his calcium, 13.5. So that's elevated, and always remember, and that's, talk with the students, always correct your calcium. So you already have a 1.5 drop in there, so add that. So you'd be adding 0.8 for every one, so that's 1.2 added to this, so the corrected would be 14.7 is the calcium. The corrected calcium level is 14.7. So this is hypercalcemia, and we don't know what's causing it. This can be a non-malignant, as hyperparathyroidism. Hyperparathyroidism, and I don't see this very often, but when you see hyperparathyroidism, the levels are not typically of calcium are not typically this high. Some granulomatous diseases that does the activation and the peripheral activation of vitamin D. Some people, the vitamin D intoxication, lithium and thiazide can also cause hypercalcemia. Now, to my side of the business, that's when you have osteologic cancers. So in solid cancers, this can be breast cancer. In hematologic, this can be breast cancer also, and through a lytic approach, you can have that with a multiple myeloma. Lymphoma and leukemia can do that as well. However, if you have a PTH-related peptide mediated hypercalcemia of malignancy, this can happen in multiple different malignancies, as you see here: squamous cell, renal cell carcinoma, bladder, breast, ovarian, non-Hodgkin's, sometimes even leukemias and lymphomas. So you do that. And then with the some other malignancies can work through the increase in the 125 vitamin D, and that would be through the mechanisms and that would lead to activation of vitamin D, and this happens in non-Hodgkin's and sometimes in Hodgkin's lymphoma. So this lady presented with what looked like an elevated total protein, if you remember, and her albumin was low, so the protein is not high because she's eating good, because her albumin is low. The protein is high because of an M spike, right? So she's making inappropriately a ton of IgGs. It's defined here as IgG kappa, and that's because she has a multiple myeloma. So there are crazy plasma cells that are causing this to happen. All right, what would you do? So this is a hypercalcemia malignancy. Always IV fluids. Similar to TLS, IV fluids is always the first approach. IV fluids, IV fluids. And again, as I mentioned that before, 250, 300 mLs an hour. Don't stop the fluids after you bolus them with a few liters, because they're behind. Bisphosphonate is one approach. Bisphosphonate has a longer lasting effect compared to IV fluids. So if you're going to intervene with IV fluids, know that you will be able to bring some of the level of the calcium level down, but you're not going to last long once you stop the fluid. So you want something that lasts for a few weeks, and bisphosphonate can do that by inhibiting osteoclasts and leaving the osteoblasts functional, so the calcium is getting bound in the bone. And if that is not working, you can go to your fastest approach, which is calcitonin. Calcitonin usually works within 12 to 24 hours. You will see the calcium level going down. We don't use calcitonin all the time unless it's a severe hypercalcemia, like you're on the border of intubation because of altered mental status or having seizures and such. Then you can go that route. These are the mechanisms of hypercalcemia malignancy. as you see, majority are PTH-related peptide hypercalcemia, but some is from lytic lesions similar to multiple myeloma, overproduction of 125 vitamin D, PTH-mediated hypercalcemia, is parathyroid carcinoma, and ectopic productions are examples of that. All right. And those, we have already mentioned that, but be clear on that. When you check the level, you start with the PTH first. If the PTH is low, the intact PTH is low, then check the PTH-related peptide and you'll find it high. And that takes you to these list of malignancies. However, in osteolytic lesions, you'll have a low or low normal PTH-related peptide and a low intact PTH because it's independent of PTH or PTH-related peptide here. In these situations, if you check the 125 hydroxyvitamin D and you find a low intact PTH, then you're talking about a hypercalcemia secondary to overproduction of 125, and interestingly, that responds to steroids, so keep the steroids in mind. This happens in Hodgkin's lymphoma, ovarian dysgerminomas as well, and things that are PTH mediated, these are R, and you will check the PTH level and you'll find it elevated. So an elevated PTH can tell you that it's one of these malignancies, and that's the least common mechanism. All right. As we mentioned before, whenever you have an elevation, get a corrected calcium based on the albumin level, confirmed on the repeat levels, check your PTH, and that takes you from one to the other. As we mentioned, we have already kind of talked about this, but now this is the management approach. So if it was a non-PTH mediated hypercalcemia, so it's not a hyperthyroidism, it's not through hyperparathyroidism or a primary hyperparathyroidism, then you need to look into, is it a PTH-related peptide or not? So if it is PTH-related peptide, then you know the malignancies that we talked about. And then if you see a 125 elevations, they check the 125 dihydroxyvitamin D and see if that is elevated, then possibly these are either lymphoma or sarcoidosis or the granulomatous disease. But if it's only the 25 hydroxyvitamin D, maybe this person is taking too much vitamin D, and if not, then check their SPEP and UPEP. You usually don't go in this approach that way, but that's how you, if you want to control yourself and test things one by one, that's how you end up with the diagnosis as well as guide you to what would be the appropriate treatment. And if you get an SPEP, UPEP, and serum free light chains, and they're all normal, and you can look for vitamin A intoxication or hyperparathyroidism. But if you caught the diagnosis of myeloma based on that, then go with it. Alrighty, so if it is mild, not like the patient that we presented, the calcium is less than 12, just tell them oral hydration. You can correct that just by drinking more fluids. All right? And start treating the underlying cause. While if it's moderate, it depends. If it's moderate but symptomatic, then that's likely acute and something that needs to be intervened upon right away. While if it is a chronic problem and asymptomatic, then you might treat it as mild and start the treatment of underlying cause and encourage treatment. Okay. Severe hypercalcemia, that's when you go wild with the fluids and bisphosphonate, and you would consider hemodialysis if you're unable to control it. Denosumab is another factor. So between denosumab or bisphosphonate, it's a controversy whether you should not use bisphosphonate in a renal failure, because it might be an acute situation where things get better by controlling the hypercalcemia here and the kidney function improve right away. But generally speaking, you would say denosumab if renal failure, bisphosphonate if not, if the patient is not in failure, and then steroids is another option, especially if you see an increase in the 125 hydroxyvitamin D. Always treat the underlying cause. All right, here's like talking about the doses. and the options for each drug if you end up using it, and the mechanism of action, and if you need to make any modifications based on the underlying kidney or liver disease. But as I mentioned, calcitonin works even faster than I mentioned earlier. It's renears us within 4 hours. And be mindful of the side effects of what you're going to be giving the patient, because you will see it. And that's in a nutshell how we manage hypercalcemia malignancy and its differential. So we've covered now superior vena cava syndrome, tumor lysis syndrome, and hypercalcemia malignancy. Let's talk about this and see. So this is a patient this is the same patient, but we're going now. During her hospital course, the lady that we were just talking about, diagnosed with an IgG kappa multiple myeloma, we got physical therapy to work with her so she can get a little stronger. But suddenly she experiences severe back pain with bilateral lower extremity weakness and numbness. What is your concern now? Here is your concern. So what happened here is this person suffered a compression fracture that caused spinal cord compression, and you see that. How would you approach a malignant spinal cord compression? Of course, this would be more lively if I was able to hear the people talking, but since we're recording it, we'll keep going. So the most common culprit cancers of cord compression are these: breast cancer, prostate, lung, renal, non-Hodgkin's, and myeloma. So why is this an emergency? This is a spinal cord compression, and if you are not able to fix it within hours, those neurologic deficits can sustain and not be regained. So you have to be very careful and very fast in that approach. All right. Spinal cord compression. Certain cancers are more prone, most common in the thoracic spine. And don't wait for lower extremity weakness or numbness or incontinence of the urine and stool. Don't wait for these symptoms to occur, because most of the time the patient is only complaining of pain. That's all what they have, just pain. So, be very vigilant in patients who have a known diagnosis or freshly diagnosed with a cancer, that this might be the case and we need to investigate it and treat it. Initially, steroids would work if a patient is having this secondary to a steroid responsive malignancy like leukemias or lymphomas. And dexamethasone is usually our choice. And then studies has been done, radiation versus no radiation, but radiation alone versus radiation with steroids, and it seems like steroids won by a small difference here, but it's significant statistically, of 18% as the patients were ambulatory, those who got steroids versus those who did not. Surgical decompression sometimes is the only way to go in certain malignancies that are not as responsive to radiation, or they will take time. Surgical decompression followed by radiation leads to a significantly higher chance of ambulation than XRT alone. So you have to look at what's the disease, how sensitive is it to the radiation, because you might have to take the patient, get the neurosurgeons to take the patient to the OR if this patient stands a chance to walk again. All right. Steroids plus surgical decompression followed by XRT versus steroid and XRT, and you see here the difference. So the standard is always to have a surgical intervention unless you're 100% know that this patient has something that will dissolve so quick with the steroids and radiation. Otherwise, you're doing your patient a disservice in not pursuing surgical decompression. And sometimes you have to push your neurosurgeon to work on the case. All right, so that's spinal cord compression. All right, another disease. So we talk about spinal cord compression, hypercalcemia, TLS, and superior vena cava syndrome. Now we'll talk about a 64-year-old man who comes in with acute respiratory distress, found to have a white count of 153,000 with 71% blasts. You check his labs, he has an elevated troponins, cardiac enzymes are up, and chest x-ray shows bilateral opacifications. Peripheral smear shows large immature cells with our rods. Sort of handed the diagnosis down there, right? So what is your treatment approach here? So what does this patient have? This patient has leukostasis from hyperleukocytosis from acute myeloid leukemia, and that is causing end organ damage, as you see his lungs and heart are suffering. So you need to intervene on the active coronary artery disease. You can't wait for the leukemia sometimes to intervene, because he is going to die very quickly, and start the treatment of leukemia. Leukostasis is any patient who have more than 100,000 circulating WBC with a blast count, absolute blast count over 50,000 at least, with end organ damage, either an end organ ischemia or hemorrhage. Myeloid cells are larger and more rigid than lymphoid cells, and you will expect more leukostatic pictures in myeloid compared to lymphoid. And that's not just because they're larger and stickier, but because they also secrete certain inflammatory markers that causes endothelial changes and renders the patient more prone to complications in major organs. Alrighty, so what are you looking for? You're looking for neuro, cardiac, respiratory symptoms. These are the three most feared complications that you have to keep an eye out for in patients who are newly diagnosed with AML. Priapism is also another sign. Immediate reduction of the number of leukemic cells can restore organ function and allow for subsequent anti-leukemia therapy. So this cytoreduction can happen in two ways. You can do that pharmacologically. Cytoreduction pharmacologically can happen in myeloid hyperleukocytosis with hydroxyurea. Our practice tends to be a high dose of hydrea, 4 grams twice a day, and you give that even orally, and you will see the effect in a few days. But if it's a lymphoid hyperleukocytosis, steroids are more effective, and use also sometimes cytarabine. Vincristine can also, I also use cyclophosphamide. Vincristine has been also used as a cytoreductive agent in malignant lymphoid cells. Cytarabine is effective in both, and anthracyclines is used in the acute promyelocytic leukemia of high risk, and we'll mention that quickly in a bit. And then there is mechanical cytoreduction. That's by putting a dialysis catheter in the patient, like a Shiley or a Vascath, and connect the patient to a pheresis machine, where you get rid of all the white blood cells and give him the rest of his blood back. These are effective temporarily. They don't last long. I do them only in the cases of leukostasis without the diagnosis of APL, and of course with correction of DIC if that happens. because those tend to bleed significantly from the procedure. So you have to be extremely careful. All right. Remember that these are interventions that you do while you're waiting to confirm your diagnosis. Once you confirm your diagnosis, you're starting the appropriate therapy for that patient. So if you have an AML and patient 7+3 is the way to go, then start the chemotherapy, because that's the longer lasting fix for this condition. All right. So comparing the two approaches of cytoreductive therapy, pharmacologic, it's not invasive, you can give it right away, it doesn't cause too much trouble early on, you're weighing the risks and benefits, you might not be having too much risks as you throw it at the patient, especially in patients with APL. However, these patients also can have some off-target toxicities because of these drugs, similar to Hydrea, for example. You'll drop everything as you give it, and it has been discussed in our expert panels when they discuss the what is the appropriate way. Let's say a patient comes in with a hemoglobin of 5 and a white count of 160,000 with absolute blast count of over 100,000. Would you transfuse the patient blood and then do leukapheresis, or give Hydrea, or where are you starting here? And the sequence is definitely a point of discussion rather than an absolute right or wrong. Mechanical methods, what goes for it is that you can get the job done very quickly. It's a matter of a couple of hours, and you can reduce the total circulating white count significantly. However, that is an invasive approach where you have to put a catheter in. And with that, you have to be careful. Alrighty. So time is clicking and almost 10 minutes to go. So last emergency. So 70-year-old male presents with intractable epistaxis, bleeding from his nose and shortness of breath. You get a CT of his chest, mediastinal lymphadenopathy. His hemoglobin is only 5.2. The total protein is elevated. You get an immune fixation, and you'll find an IgM kappa protein, and and the IgM serum level was significantly high. And see 8,000. The upper limit of normal is 263. With a serum viscosity over 5. You get a bone marrow biopsy, and for plasmacytic lymphoma, or what we also call Waldenstrom macroglobulinemia. All right, so what is the emergency here? The emergency here is hyperviscosity. So hyperviscosity comes in most commonly with bleeding, blurred vision, headache, and dizziness. These are the most common, but it can come in multiple different other shapes: nystagmus, deafness, ataxia, confusion, even a stroke, or a patient going straight into a coma. The diagnosis: check the serum viscosity, do a fundal exam by your ophthalmologist. You will see venous engorgement and some hemorrhages and exudate. It is unlikely to have a patient with hyperviscosity if their viscosity index is less than 4, so usually anything more than 4. IgM is more than IgG. So hyperviscosity syndrome is one of the main feared features of Waldenstrom macroglobulinemia, or lymphoplasmacytic lymphoma. And that's because this guy, IgM, is much bigger in size compared to IgGs, like 4 or 5 times the size. Waldenstrom macroglobulinemia, elevated monoclonal IgG level due to an underlying lymphoplasmacytic lymphoma. That's so the definition of macroglobulinemia is just with an elevation IgM. Waldenstrom macroglobulinemia, it's when the IgM is up because of LPL, and the symptoms of lymphoma and of elevated IgM is hyperviscosity in 30% of the cases. Alrighty, so how would you treat that? So that's an emergency that needs another type of pheresis, Not leukophoresis, like the mechanical cytoreduction in leukostasis we were mentioning, but plasmapheresis this time. So you hook the patient, put the same catheter in, hook them to the same machine, but instead of getting rid of their white blood cells, you would get rid of plasma, and you give them albumin instead. You replace what you're taking away with albumin, and this can promptly reverse the most of those clinical manifestations of hyperviscosity, because IgM predominantly stays intravascular, so you're able to correct it very quickly. All right, that though does not last. So plasmapheresis or plasma exchange is not something that fixes your hyperviscosity on the long term, and you have to think of what else am I going to do. So if you're going to treat this patient, and likely you are going to treat Waldenström macroglobulinemia, if they are developing this, you need to treat them. If part of your plan is to give them rituximab, plan on doing plasma exchange prior to rituximab. And the reason why, rituximab can lead to an IgM flare. And when IgM flare occurs, it can lead to a hyperviscosity syndrome, even if there was no hyperviscosity syndrome. Because then when it flares, viscosity goes up, hyperviscosity symptoms come up, and then the patient needs plasmapheresis. So instead of doing that, just do plasmapheresis before the rituximab, especially if you're starting at a deficit. So if your viscosity index is already flirting with over 4 or at that goal, at that number, even if the patient is asymptomatic right now, it might happen, okay? And treat the underlying disease, and that's what I was mentioning with the rituximab plus, let's say, bendamustine. That's one of the treatments. Or if you're going to go for ibrutinib or zanubrutinib or others for your Waldenström, that's all other approaches that can be done. All right, so 5 minutes before the end. I don't think I'll be able to check another topic, but we basically touched up for a quick review on SVC syndrome, tumor lysis syndrome, hypercalcemia, malignancy, spinal cord compression, leukostasis, hyperviscosity syndrome. We do not have time for TTP, one of my favorite topics, but we'll discuss it later. And all these are other topics that has not been discussed, and we can have that in another series to go over. I don't know. I'm recording this, and I know that it's maybe on a live, but Discord, but if I don't know if anyone here can. I don't know if I can see any comments, no messages, or all right. So no questions. Since there's no questions, I will get going, and I'll save this for a review by others in the future. Please let us know if you have any questions. You can always send me comments or messages directly through the page or my personal page. And thanks to those who participated. Yalla, Assalamu alaikum.